So our next speaker is Dr. Phil Scott from the UK. Phil spent a considerable amount of time in the University of Edinburgh, but has now since left, and he is a consultant with Capital Veterinary Services in the UK. His talk is on comparison of ultrasonographic findings obtained using a 5 MHz linear and microarray scanners in cattle with lung and pleural pathology.
Thank you very much, Cliona, and good morning, ladies and gentlemen. So what I'd like to do in the 12 minutes available is to take a step back to clinical practice and attempt to convince the practitioners in the audience that we can get meaningful results with a linear scanner in 2 to 5 minutes. So your time on the farm is costly to the farmer, and we don't have the time to spend thoroughly examining the chest. So would a simple measure, scanning both sides of the chest with a linear probe, give us meaningful results? So that's the aim of my talk. So there's this general misconception in general practice. I was in first opinion practice for 38 years as well, that we need convex microarray scanners to get meaningful results, and a linear probe is only useful for examining the reproductive tract, although Professor Koffler made a very good case, and I would agree wholeheartedly, that we can use linear probes. So unfortunately, I don't have the time to show many video recordings, in fact any. If you'd like to download them free of charge, there's no need to photograph the screen. They're available free of charge. They're also available on a website called NADIS. And unfortunately, Professor Bugzinski's excellent ultrasound edited textbook will now be out of sale because everyone's plugged it so much. So you can download the images and video recordings if necessary. So how do I sell the concept to you as practitioners? Well, commonly at the University of Edinburgh, where I worked for many years, we would receive the cow, well, rather a heifer, on the top left-hand side. And there would be a vague diagnosis of respiratory disease and the belief that the animal suffered from Mannheimia, so would be treated with a fluoroquinolone. So on admission, the animal would show vague clinical signs of inappetence, very poor production. You can see the sunken sublumbar fossa. It's got a slight mucopurulent nasal discharge, but that's it really. And importantly, these animals are afebrile. They often have a rectal temperature which is normal or below 39. So we see that animal after 3 days of treatment with a fluoroquinolone, believed by many practitioners to be the gold standard treatment for respiratory disease. We then change the treatment to penicillin, and 10 days later, you can see the difference. It's not been airbrushed. It's much cleaner because it's been in a better environment, but there's nothing else. It's the same animal. You can see the slight umbilical swelling. The white markings are the same animal. So we'll hear later from speakers talking about the use of ultrasound to diagnose anterior peritonitis associated with traumatic reticuloperitonitis. So the animal on presentation on the left-hand side of the screen shows an arched back, head held lower, slow to move, neck extended with a painful expression. And then the animal 2 days later, after a change of treatment once again, much improved. And the basis of that treatment change was founded on ultrasound examination with a linear probe. So why the dramatic improvement when changing from a fluoroquinolone to penicillin? Well, what we're treating in these animals is not lung abscesses. We're treating a bronchiectasis, and the definition is there. I'm not a pathologist, but what is important is a bronchiectasis condition. The major pathogen is Trupperella pyogenes. In a former life, it was Actinomyces pyogenes, and before that, Arcanobacterium pyogenes. It's particularly susceptible to penicillin, but not fluoroquinolones. So that is why we get the treatment response. We're not treating lung abscesses, we're treating bronchiectasis. We're treating mucopus in the major airways. And auscultation, importantly, does not delineate nor define the pathology. And how can we say that? Well, you can go on the internet and download a whole range of MP3 recordings from lungs where we've synchronously scanned and recorded the lungs. So on this picture here, we can scan and auscultate at the same time. And you'll be greatly disappointed by your auscultation skills. In fact, to the point now where I won't auscultate a chest, I can scan it more quickly and give more meaningful results. So a stethoscope goes in the bin. And if you want to download these sounds, and if you want to read the literature, Professor Bugzinski is following me. We've not collaborated apart from various, I did contribute to his book, hence the promotion. But in cattle, in sheep, you can find publications, download the images, etc. So very briefly, what generates a crackle? Well, a crackle is generated by mucus pus in the larger airways. So if we look at the position of these larger airways, and in particular the trachea, in relation to the pathology is delineated in this animal here below the white line just at the probe. What we hear are crackles in the trachea and larger airways dorsal to the pathology. And when we examine these animals with chronic respiratory disease, we frequently detect halitosis. And if the animal holds its head down for any length of time, there's mucopus accumulating on the floor, which we see in the bottom right-hand image. That material is not coming from the abscesses or chronic pathology. It's coming from the airways, and that's what we're treating. So if we take a radiograph and look at the position of the pathology, and the next image in the center shows the pathology, and importantly, the pathology is horizontal. So a single measure of the pathology will indicate, in most cases, the extent of the pathology. So what we hear are sounds generated by mucus pus in the larger airways dorsal to the pathology. So your ultrasound machine, your rectal probe, is much more accurate than auscultation. And the field depth is of no consequence. Why is that the case? I'll come on to that. But there is an advantage of a linear probe in that the contact length is much greater. So when we're looking for the, just trying to press that, the change from normal lung to pathology, we get a much easier picture to interpret using the longer probe head. So in fact, your linear probe is an advantage to you. So why is depth of field not important? When we look at these pathology examples, we can see the heart here. The pathology extends for the full depth of the lung. If the lung is affected superficially, very quickly the full depth of the lung is affected. So we just need to look at the lung surface. And then if we do a necropsy on a typical severe case, we can see the largely horizontal distribution of the pathology, the dorsal margin of the pathology. Therefore, a single measure will give us a very good indication of the area. And once we know the area, we can determine the volume. So when it comes to examining a cow in practice, we just need to measure the dorsal distribution of the pathology from the point of the elbow. So we can shave the chest, examine both sides of the chest with a linear probe in under 2 minutes with a little bit of experience. So here we see the animal shaved, ready for examination. Now, in some cases, you will see lobular distribution. If we take a vertical plane, we can see a consolidated lobule, a normal lobule, and this is reflected in a linear probe. My images are different to Professor Koffler's. Dorsal is to the left. But this is the consolidated area here, which would be representative of the lobular distribution in this animal. And again, we see it here, and what we've done is compared a microarray or sector scanner with a linear scanner. So we get largely the same picture. It may not be the same lobule, but we're scanning in a vertical plane. And you can see the largely horizontal dorsal margin of the pathology, but in some cases there is this lobular distribution, which is well represented here. And this is what it would look like on post-mortem examination. But in the vast majority of cases, there is this abrupt change from normal lung to consolidation, and we see it more obviously here. So we go from normal aerated lung to extensive lung pathology, which is largely horizontal in its dorsal margin. So when we use our rectal probe, what we see is this abrupt change into consolidation. And that would be the same if we used a microarray probe to a sector or linear scanner. So that is what we typically see. And when it comes to the hepatoid change in severe cases, it looks like liver in both cases. We see the same if there's abscessation. A linear probe will give us exactly the same picture. We don't have the depth of field. Where there is a slight problem is where, in this case, an abscess extends to 16 centimeters. We can see the dorsal margin of the capsule, the ventral margin of the capsule, but with a linear probe, we don't see the distal capsule. So it doesn't really matter, but it's not as accurate. So when it comes to a pleural effusion, we can estimate the pleural effusion by how far up the chest wall we find the lung. So we find the lung, and if it's 2/3 the way up the chest, we know there's going to be 50 liters of fluid in the chest. So what's the prognosis and diagnosis for these two animals? How can you tell? Well, you scan them. And this, if there's one image or one slide to remember, this is the animal on admission. She's got a nasal discharge, she's not eating. So we come up with a specific diagnosis, informed antibiotic therapy, much better clinical outcome, and improved animal welfare. These are the same two cows. This is the same two cows, the same cow rather, separated by 6 weeks and penicillin treatment. A similar case here, a severe animal or severely affected animal, and after treatment. So, with your linear probe, what we look for is a very sharp demarcation in a vertical plane measured from the point of the elbow. And always scan both sides of the chest. Unilateral lesions are very common. So this is what we're looking for, 2 to 5 minutes work. Much quicker than auscultation and much, much more informative. We use penicillin, which gives me a perverse pleasure in going backwards in time to my time of graduation. So thank you very much, and I hope I've convinced you of its usefulness.
Thank you, Phil. Is there any questions? We have time for one question.
Thank you very much. In a lot of cases, I had such situations that the change in lung parenchyma was not in the cranial part of the lung, just in the very caudal part of the lung and just in a very small area. So it's possible that we overlook such cases if we just make sonographic detection just on a very small part in cranial part of the lung.
Well, you scan 2/3 of the lung, and in these animals where there's sufficient lung pathology to cause severe clinical signs, there will be that amount of pathology, and because the infection is aerogenous, it will be a cranioventral distribution. Granted, there may be some lesions you miss caudodorsally, but they're usually hematogenous in origin. So I would say it's unusual, and in the PM specimens I showed, there was no caudodorsal distribution. So I would say in 99% of cases, a single rib space, 5th to 6th intercostal space, will give you the information you require on a time-restricted basis. I would agree with Professor Koffler, we should scan the whole lung field, but when you're charging €2 per minute for your time, farmers can't afford it. So it's a compromise. So errors may occur, but they are infrequent and much better than auscultation.
You've obviously looked at kind of heifers or mostly adult cattle. Is it applicable to young calves, 2-3 weeks old, the same, just scanning behind the elbow?
If there's extensive, or if there is consolidation, I think Professor Bugzinski will address that in more detail in young calves, I believe. And certainly his recent articles have focused on that. So I leave him to describe his work. But yes, certainly his articles have informed me of that, yeah. Sorry, I'm not trying to dodge the question. I just think we have a...
It is the next talk, anyway.
You may miss 50% of the cases if not screening both sides. And you need also to go cranial to the heart because sometimes it's very focused on the cranial part of the heart, which you cannot easily access in a calf.
Okay, thank you very much, Phil. That's great.
You're welcome.